And then already President Dr. Anthony Teo will perform the opening remark. However, he had an emergent operation. He unfortunately not joined this meeting. So instead of him, I will do the opening remark. Good morning, everyone. Welcome to these first deep sessions, Deep US Educational Program, first time. Today's theme is Invisible to Visible. We'll focus on the challenging cases where US made an important difference. Thank you to all speakers and the participants for joining us. And then I hope this time will be interactive and educational. Please give us a lot of questions and then comment. Okay, let's begin. And then it's my great pleasure to introduce Dr. Bhatia from India. He's a distinguished expert in US and the biliary pancreas area. We allow deliver our expert mini lecture on challenging difficult cases in US. Please, Dr. Batia.
Yes, thank you so much, Professor Tai-Hyun Kim, for taking this initiative. And I shall share my screen. So are my slides visible?
Okay, I can see.
So, okay, Dr. Ichiro, am I visible? Can I proceed?
Yes, very clear.
Okay, thank you so much. So it's a pleasure to be part of the first Deep US education program. Again, thanks to Professor Kim, Dr. Anthony, and my co-moderator, Professor Ichiro, to be here. I hope I can challenge you with some diagnostic cases in US. And US is based on careful observations. And well, let us see how observation helps us in day-to-day practice. So we will obviously cover part of diagnostic US. I shall take you through around 7 or 8 cases if time permits. I shall show you some unusual encounters during pancreatic US. Something which we should do, but we don't often do, US evaluation and sampling of the small bowel mesentery. We all drag through the heart without paying much attention to it, but maybe we can start peeking into the heart during US. And we all encounter multiple lymph nodes. And let me show you how you decide whether the nodes are benign or malignant by careful observation alone. So let me begin by a case of pancreatic US. And this is a 77-year-old male with hypertension, hypothyroidism, diabetes poorly controlled. He had 3 episodes of acute pancreatitis 2016, 19, 20, and since last 5 years, he has been well, except that he has lost a lot of weight. And now he has many non-bloody stools with significant mucus passage. His CA19-9, if you see my arrow, is high. CEA is also high. He came to me with CMRI and a FDG PET. These showed multiple cysts throughout the pancreas. The image was interpreted as multiple branch ducts, no enhancing nodule, loss of fat plane with the colon, and FDG PET was reported as a synchronous carcinoma of the colon along with possible IPMN. So if you look at this video, which is running, this is imaging across the posterior gastric wall, and this is where you expect the pancreas to be. And then, well, let me make it easy for you. Initially, I was confused, but later on, you see that the whole pancreas is replaced by these multiple cysts. Observing carefully, the contents of the cysts are different, which means that they are non-communicating. There are multiple huge, large nodules, masses filling the entire pancreas. And if you look at the echo texture, this is a classical mucin streaks. So careful observation means that we can immediately look and say that, look, this is mucin. It is a streaky sort of a appearance. This is where the tail of the pancreas rounds off. So my impression was a huge distended MPD in the tail filled with soft tissue. This is a contrast. In India, we use Sonoview 4.8 ml bolus. just to be very sure that these are not odd-looking necrosis. You see that these tissues are vascularized, so hence these are actually living tissues, likely huge IPMN main duct filled with adenomas. Very interesting finding from D2. If you can see my arrow, can you see my arrow, Dr. Yasuda? Dr. Kim, can you see my arrow? Can you hear me?
Yes.
Okay, so this is the how we demonstrate the papilla from D2, if you see, and this is the EUS fish mouth. I call it a EUS fish mouth. See how wide the pancreatic duct is, and even in real time you can see it pouring mucin, another large duct draining into it, a nodule, and if you look carefully, you have the classical endoscopic fish mouth in the video on the right, and in fact there are two fish mouths. Here the MPD is hugely dilated, filled with mucin, mural nodules. So there is a minor papilla fish mouth, there is a major papilla fish mouth. Very interesting. So the entire MPD is hugely dilated. We also did a colonoscopy, and this was the splenic flexure mass. Now, if you look very carefully, this doesn't look to be a typical adenoma. The gentleman is actually pouring mucin through this. So we took some biopsies and this was MUC5AC positive, which indicates a gastric origin, gastric type IPMN. MUC1 is equivocal. If it is positive, it indicates aggressive disease. MUC2 and CDX2 negative, which practically rules out a colonic tumor. So it was basically IPMN gastric type fistulizing through the colon. And now if you review the CT films where my arrow is, you can actually see the little rent. So it's a large main duct going and the whole tumor tissue is projecting into the colon looking like a colonic tumor. The mechanism of these fistulization can be direct invasion by the tumor, a mechanical penetration, which means that the pressure itself leads to a rent and it can lead to fistulization and obviously autodigestion. A very, very rare phenomena. And most of these fistulizing tumors are intestinal type. Most commonly, you find a fistula of IPMN in the stomach, duodenum, bile duct, and only 5% fistulizing tumors go in the colon. But a case that highlights how important it is for careful observation. Let me just run through. I want to show you many, many cases. Here is a male with NASH cirrhosis, diabetes, no alcohol use. He came to me with a CT, MRI, PET CT scans, everything done. We showed a hypervascular pancreatic tumor with MPD dilated and CA19-9 normal. So there are many discordance. Pancreatic ductal adenocarcinoma is not hypervascular, but a MPD, if it is dilated, well, would suggest a ductal adenocarcinoma. So there was a sort of ambiguity in the imaging findings. Let me show you. So this is imaging from D2. This is the downstream MPD where my arrow is. Here is a round tumor, but again, careful observation shows that this is a bit well demarcated, too well demarcated for a ductal adenocarcinoma. It can happen. And the upstream MPD is well dilated. We did a contrast and it was enhancing. This was the ERCP finding, lower MPD, the CBD, the tumor and upstream dilatation. By that time, I had already done a FNA, shown it to be a neuroendocrine. I just took the pancreatic juice and even the pancreatic juice showed neuroendocrine tumor cells. So this was a pancreatic net with MPD obstruction, not a ductal adenocarcinoma. We were practically sure after a contrast EUS, and these patients are not very uncommon. They will often present to you with recurrent acute pancreatitis, pain, upstream parenchymal atrophy, pseudosis. The point to remember is that there is some data that these obstructive MPDs have an aggressive clinical course and they should not be observed or stented, they should be operated. I don't have time to go into the mechanism of it. Now let me show you the EUS evaluation of the small bowel mesentery. This is case 3. This is a young male with pain abdomen since 4 months, weight loss for 10 kg, mild fever, prior cervical lymphadenitis, likely tubercular, no addiction, alcohol use, HIV negative, MON2 15, and a PET CT showed avid abdominopelvic lymph node, mild ascites or mental nodular stranding. So the differential is of abdominal TB, but even in a young male, carcinomatosis remains a possibility and we do need a tissue. So this is a transgastric EUS. If you observe carefully on the liver surface, we find this little scalloping. Can you see this? Very, very tiny, tiny deposits. Don't look like typical lymph nodes. These are, to me, some deposits with scalloping of sorts of the liver surface. Let me move it forward. We can biopsy these little things, which are still only a few millimeters across, but we can take a biopsy from these. We can also look down from the stomach through the gastric posterior wall and the greater curve into the inframesocolic compartment. And this is where we gaze through the transverse mesocolon into the small bowel loops. If you look at the arrow, I like to put a lot of water in the small bowels in such cases, so it sort of distends, and I can look very nicely into the entire proximal jejunum for any mural pathology, something I have become very fond of. So the jejunum can be seen very easily on EUS, and you see the jejunal loops, but you also see the small bowel mesentery is diseased, is hypoechoic, the fat inside seems to have been displaced, definitely abnormal. And then we can pass a needle and we can biopsy this mesentery. You would also have noticed multiple small lymph nodes scattered in the small bowel mesentery. And we can biopsy these, and well, we found granulomas, necrosis, lymphocytes, giant cell. ZN stain was negative, but gene expert, which is PCR, was positive, and mycobacteria culture was positive after 6 weeks. This patient is on anti-tubercular treatment with a histological diagnosis. How do you visualize the small bowel and mesentery? As I have said, water filling in and it only helps. So I just take my US to D2, D3, put in a lot of water, distend the jejunum, and then we see along the posterior wall greater curve of the stomach. This is a window to the mesenteric root and proximal jejunum. In peritoneal TB, mesenteric abnormalities are seen in a significant promotion, most often hypoechoic thickening. We see nodular thickenings, we see adhesions, lymph nodes, parietal peritoneal thickening, and also omentum. So if the omentum is thickened, I haven't shown you, but we can actually distinguish the omentum just outside the gastric wall on the US. So very easy to biopsy, good yield. Let me move on. Again, something which most of us don't do. When we withdraw the scope, we just pull over the heart, but should we actually do it? Before I show you two cases, let me just give the audience a very basic overview of how the heart looks during the scope withdrawal. This I call bicable view and right atrium. So the left atrium is close, the right atrium is far. We can see the IVC coming from below. We can see the SVC coming from above. At the junction, we have the crista terminalis. This is right atrial appendage. This is pectinate muscle. This is interatrial septum, which is important place to look for the patent foramen ovale before you inject glue with EUS. We rotate to the left and we get a mid-esophageal two-chamber view. Two-chamber view means left atrium and left ventricle, and this is where we want to look into the left atrial appendage. This is where patients with pancreatic cancers develop clots, and it is good to peak at this site when we are withdrawing the scope, maybe. This is how we see the aortic valve. Very commonly, we find pathologies here, so it is good to look here. And these are the two pericardial sinuses, the transverse sinus and the oblique sinus. We can easily pick small amount of fluid here, and oblique pericardial sinus can be confused with subcarinal lymph nodes, and you can puncture and cause purulent pericarditis. I am sorry for rushing here, but my time is going fast. So I'll show you two cases. This is a 36-year-old male post-LDLT with a suspected seroma oblique bilioma, and the surgeon sent this patient to me for single time EUS evacuation. So after the evacuation of the bilioma, when I was withdrawing, this is the aortic valve, and you see something is stuck onto the aortic valve. And this looks like a vegetation, but then a vegetation oscillates much more vigorously. So I called it a organized vegetation or a thrombus. Differential would be a nodule of Arrhenius, but likely a vegetation. And this was missed on transesophageal echo, and subsequently the cardiologist confirmed this. So good to know that this patient had a bicuspid aortic valve and a vegetation hanging on it. Incidental pickup. Another patient of CKD on hemodialysis via a permacath catheter had enlarged mediastinal lymph nodes for FNA, which I did, showed it to be tuberculosis. But just I was looking around, and now look in the right atrium, you see the catheter coming in from the SVC, and there is a thrombus on the catheter. This is the eustachian valve and the pectinate muscles and a big thrombus in the right atrium. And this is the permacath catheter, which has thrombus on it. Both very significant findings for the patient, and both are life-threatening findings. So what do I recommend? Should we look routinely at the heart in all patients? I don't think that is possible. But as endosonographers, we can look for left atrial thrombus in our patients of malignancy. We can look at the aortic valve. If the patient has an intracardiac catheter devices, particularly even a central line, we can look at the tip. We can look for patent foramen ovale before glue injection. And we can look for right to left shunts with agitated saline. This is the bare minimum. We can do a lot, but this is very easily possible for us. Now, my last part of my talk. Dr. Kim, can I have 1 extra minute, please? What's my timing like? Am I audible, Dr. Kim?
I think your time is okay. Just 5 minutes is available. Okay.
So sorry, how much time do I have? 5 minutes?
5 minutes. 5 minutes.
Okay. So this is my last part, something very interesting. So we often encounter lymph nodes when we do EUS, and then the thing is whether we should puncture, whether it is benign or it is malignant. Let me show you how. This is the normal ultrasound sonographic architecture. Let us recapitulate this. These are longitudinal hilar vessels. So the lymph node has a hilar and the lymph node has a echogenic medulla. This is the medulla. Outside the medulla, we have the hypoechogenic cortex, and then there is a capsule. Lymphatic vessels enter across the cortex and exit at the hilum. Vessels enter through the hilum, and then they branch centrifugally inside the lymph node. This is a normal lymph node. Now, what are the EUS features suspicious for malignant lymph node? In the next slides, I have highlighted the benign features with yellow, malignant features with pink. So as the lymph node gets infiltrated with a cancer, the normally oval or elongated lymph node becomes round. So a long to a short axis diameter less than 2 is defined as round. More than that is defined as elongated, and lymph nodes normally attain a round shape. They become round instead of elongated because the tumor is filling and expanding the lymph node. The lymph node can also become irregular, but it becomes irregular with spiculated margins. And this shows that the tumor has gone across the capsule of the lymph node and is infiltrating the pericapsular soft tissues. It can have sharp borders, but it can have spiculated borders also. A benign lymph node is usually irregular, but it has lobulated contour. So we must observe these lymph nodes very carefully. And the capsular interruption can also be focal. You can see these are all my cases, all biopsy proven. These are not from any textbook. And here you can see the cancer is breaking through the capsule. We also look at something on EUS, what is called the nodal core sign. What is a nodal core? This is a complete nodal core, which is normal. So a nodal core is formed by the medulla and the hilum, which appear white or echogenic. So this is a complete nodal core, the hilum and the medulla of the lymph node, clearly a benign lymph node. We in the US will often see a partial nodal core, not a complete. But if the lymph node has been completely taken away by the malignant cells, the nodal core sign is absent. There is no medulla, no hilum. It is only filled with cancer. We do see a perinodal ring very commonly around malignant lymph nodes. Next time you do EUS, look very carefully. This is edema infiltration along the lymph node. So if the lymph node has cancer, the surrounding tissues will often show edema and you will see a ring. This is to be distinguished from the perinodal fat seen in benign lymph nodes. We also now look very carefully at the vasculature of the lymph nodes. So in malignant lymph nodes, the tumor sprouts or attracts the neovessels. So they come from the capsule, they break through the capsule. This is called a transcapsular flow with a centripetal flow. So the vasculature is from outside to inside, also called peripheral vascularities. These are malignant lymph nodes. And this is a centripetal lymph node with penetrating vessels. In a benign lymph node, the vessels remain hilar. They enter through the hilum and they branch centrifugally from inside out. A benign lymph node and a benign lymph node. Last 1 minute, Dr. Kim, and I'll show just 3 cases running. This is a patient with cirrhosis, with a SOL, likely HCC. So you can see exophytic HCC very carefully. We did a contrast. I do with the TRC or tissue reduction method, hence this kind of imaging. And you see the centripetal fill-in of this HCC, it has some necrosis. So hence this kind of contrast study. But this is of concern. This is a large lymph node. And now if you see the lymph node, what do you think? Is it benign or is it malignant? Just look at all the features that we were just talking of. Just look at this lymph node. The lymph node has round shape. If you look very carefully, it has a perinodal ring. This is edema. There is no nodal core sign. The vessels are coming and circling the lymph node and breaking in from the periphery. They are breaking the capsule coming in. It has a ring-shaped flow. The ring-shaped flow is when there is a ring of vessels around the lymph node, and also something called misty vessels. When you have focal areas of these spotty vessel, this is called a misty flow or a misty vessel. Biopsy proven malignant metastatic HCC, positive for glypican and arginase. Next case, NASH cirrhosis, multifocal HCC, mild avid periportal, portocaval and autocaval lymph nodes. Again, look at these lymph nodes. Look at the features which I just told. We see that the lymph node has irregular shape, has a nodal core sign. This is the nodal core. You see a hilar vessel with outward branching, inside out. And no vessels are penetrating the node from outside. This is a reactive lymph node. Last case, this is a patient with an incidentally discovered liver SOL. And the PET and CT kept a differential of intrahepatic cholangio or a CAGB since it was. So this is the tumor and this is the lymph node. And the patient was ready for surgery except for this lymph node. So the key point was whether this is a benign lymph node or a malignant lymph node. So if you see this node has irregular shape, this has a partial nodal core sign and this has hilar flow with outward branching. So we did a FNA, it was benign, and we were confident also based on morphology because FNA can be false negative. So we sent the patient for surgery. She was operated and all the nodes were negative. So with these 8 cases, I am sorry to have rushed through. I am happy to take on discussion. Dr. Kim, Dr. Isuda.
Okay, thank you so much for your lecture and so informative by the educational cases, 8 cases, right? Too many cases. However, it's a very interesting case is maybe we can compare the endosonograph and the cardiac esophageal echo. How about you? It's I think it's the US and by US it's so very clear imaging by the US scope, and that you can give me a little some difference between the echocardio and then US.
So in a transesophageal echo, it's a sector-shaped scan. So the beam diverges very fast. We have a curved linear CLA, curved linear array transducer. So it is very good in the near field, but diverges in the far field. So this is one. Two, a transesophageal echo can be rotated. So you can get both radial as well as linear images practically, and even oblique images with the same probe. So the TE can be rotated. We get either linear or radial. But for our work, I find it is okay. I have been looking routinely at the heart. You reduce the noise, you take off compound, well, you do some minor adjustments for flow, and you can look at so many things in the heart, and it is very, very common. Patient with pancreatic cancer carrying big clot in the heart. I think this is very important. And very often we find trouble in the cardiac status of these patients, which is relevant. So I just wanted to show that observation means complete observation for the patient's benefit, not just do the FNA and rush out.
Okay, thank you for your answer. Please, Professor Yasuda, how about you? You performed the US for observing the cardiac.
We sometimes observe the mediastinum lymph node.
Yes.
At that time, we sometimes observe the heart, but I've
Yes.
never found the cardiac diseases.
Okay, I think it's maybe Dr. Batia is so very interesting and have a good the ability to detect the cardiac
Very
echo.
interesting images.
Yes. Very clear, amazing. I think
I've never seen
sometimes, yeah,
tuberculosis nodules.
yeah,
Tuberculosis,
yes,
heavy
yes,
interesting.
But lymph
yes.
nodes is something which all of us do. So I basically highlighted also a very careful observation of the lymph nodes, because sometimes we do the FNA and we get false negative. So our mind should always be clear on morphology alone. If it is positive or negative, we make more passes, or we tell the surgeon that, look, FNA is negative, but it is likely to be positive. So that is also, I think, very important for beginners.
Yes, I agree.
Okay. Ultrasound finding, you suggest the scalloping finding in the mesentery, suggestive of the TB. Okay. And then this scalloping finding is very typical finding for tuberculosis.
No, anything. So we find scalloping even with the mucinous carcinomatosis, with pseudomyxomas, with carcinomatosis. So this is not specific. But what is
Yes.
specific, if you have metastatic deposits, they will usually light up on contrast and even show some vascularity. When you have tuberculosis landing there, these are often hypovascular because necrosis is so prominent. And often on contrast, you see them as signal voids. So they are black on contrast, while metastatic deposits will often light up. This is just one soft point. Finally, they are easy to sample. So that's okay.
Okay. Thank you.
Vikram, I have a question.
Yes, Dr. Yasuda.
When you puncture the mesentery,
Yes.
mesentery is very soft, usually soft and moving. Do you have any special technique for puncture, such
So
for some
very interesting. One of the important things when a mesentery is diseased is that it gets rigid. So puncture is not difficult. It's actually so it doesn't end. It is fixed. So very easy.
Which size of needle do you usually use?
So we can use either 19 or 22. So
19 or 22.
both are fine. Both are fine. So these are for us, the most common disease here is tuberculosis, and these are not very vascular. Bleeding usually doesn't happen, and the yield is pretty good. Even in cancer, it's okay.
Okay, I think the USFNB is very important. We can avoid the laparoscopic procedure for diagnosing the tuberculosis in the tuberculosis peritoneum. I think it's very good tool. Okay.
That's invasive.
Yes, I think there's a interesting case. Another interesting case, large mass in the main pancreatic duct, right? Is you diagnosed the neuroendocrine tumor. Final history diagnosis. What is the final diagnosis?
So the final diagnosis was neuroendocrine tumor. I think the Ki-67 was 2%.
Yeah.
So it was a neuroendocrine on contrast on biopsy. And even the pancreatic juice cytology was also positive. So that was very interesting. So when you look at the mechanism of how a neuroendocrine block the pancreatic duct, many are very small, serotonin producing desmoplasia. So this was just a mechanical obstruction and direct infiltration into the PD.
Yes.
So slightly different.
Maybe serotonin producing entity, right? Okay.
Not in this case, not in this case. Here, the serotonin producing leads to more fibrosis. This was just a mass effect and direct infiltration. So even the PD juice cytology was positive. So good prognosis.
Yeah, I think in this case is very rare case. Usually yeah, the neuroendocrine serotonin producing tumor obstructing main pancreatic duct. Usual NET is not obstructive the main pancreatic duct. Very rare case, right? Okay.
Very rare, very rare.
Yes, thank you so much for your good lecture. And let's move to the cases sessions. And today also we invited two moderator. I already mentioned introduce Dr. Batia, Vikram Batia, and also we invited the well-known professor, doctor in Japan, Professor Ichiro Yasuda. As you know, he's a well-known professor in the US and then pancreatobiliary area. Please, Dr. Batia and Professor Ichiro Yasuda.
Okay. Today, three young doctors will present three cases. Probably must be interesting and educational cases. The first case will be presented by Dr. Eugene Lo from Prince of Wales Hospital, Hong Kong. Okay, first case. Okay, please start your case.
Okay. Good evening. Can you see my slides?
Not yet.
Not yet. Please wait. Let's see. Can you see my slides now?
Okay, now. Okay, please change the okay now. Okay.
Okay. Good evening, friends from the AEG group. So in today's education program, I would like to share and discuss a case with a patient with jaundice and lymphadenopathy with ambiguous diagnosis. So first of all, our patient is a 48 years old gentleman who is a smoker but a non-drinker. He has past medical history of hypertension. Otherwise, he enjoyed good past health. She came into the surgical unit presenting with a poor appetite and weight loss. And he also complained of some upper abdominal discomfort. Physical exam revealed that the patient was in jaundice and also noted the patient to have hepatomegaly. So the baseline investigation showed that the patient was a bit anemic with an elevated white cell, and the liver function was grossly deranged with a cholestatic picture, and the bilirubin was very elevated to 180. So we went on and performed a CT scan for the patient. So in the CT scan, I think first of all, we can appreciate that the biliary tree is very dilated, and the spleen is also demonstrates splenomegaly. The pancreas itself is very swollen, and there are multiple lymph nodes around the para-aortic and the peripancreatic area. So having this CT, our team, the initial impression was that this case is not a solid pancreatic tumor, but instead looks something systemic. So in our mind, we are thinking about whether this is an IgG4 disease or a lymphoma. As the patient was having deep jaundice and an elevated white cell, we performed a ERCP. The cholangiogram here, as we can see, show that the biliary tree is dilated. CBD is more than 1 cm. And at the intrapancreatic part of the bile duct, there was a very tight structure, and we put in a stent. So to further investigate the cause of the swollen pancreas and the lymphadenopathy, we went on and performed the EUS. So this EUS image are mostly taken in the gastric station. So first of all, this is the aorta and the celiac and the SMA. So the first point to note is that we find that the patient has multiple enlarged lymph nodes near the celiac and the para-aortic region. And in the body and the tail, we can see that the pancreas is quite diffusely swollen. And also there is multiple enlarged lymph nodes next to the pancreas. So in the D1 station, we took some time and observed the common bile duct. As you can see on the screenshot here, the bile duct wall is indeed quite circumferentially thickening. And there was an abrupt transition at the pancreatic head area where it was transected by the biliary stent. So we went on and performed sonofield contrast enhanced EUS. So what the pancreas has demonstrated, there are very multiple spots of hyperenhancement on the pancreatic head region, which suggests spots of hypervascularity. So, but then we turn to a Doppler and then observe the pancreas again. And similar to the contrast enhanced EUS finding, you can see that the pancreas is very hypervascular with a lot of tiny Doppler signals representing vessels. And even the lymph nodes in the celiac area also demonstrate a lot of small vessels inside. So we took FNB using 22 gauge acquired needle for both the pancreatic head and the pancreas. Afterwards, the liver function starts to improve and the IgG4 came back to be quite high. So originally we thought that, oh, we have achieved a diagnosis of IgG4 disease, autoimmune related pancreatitis. But then things start to take a turn, and the patient was still in the hospital because he was having on and off fever despite appropriate antibiotics. And he also complained of night sweat. Both of our FNB came back, although show no malignancy. The pathologist cannot commit whether this is an autoimmune pancreatitis. And we repeat the physical examination and find that the patient has multiple new onset groin lymph node as well. So PET-CT was ordered, which again demonstrate persistent hepatosplenomegaly, a lot of lymph nodes inside the abdomen with hypermetabolic activity seen, and also in the pelvis as well as in the groin area. So we went on and excised one of the lymph node for biopsy. And the pathologist's comment was that there was some atypical lymphoid proliferation, and lymphoma cannot be excluded. But at the same time, raised IgG4 staining was again seen. So basically, at this point, our team was a bit stuck. So on one hand, as an endoscopist, we think that the EUS feature is quite compatible with IgG4 disease. But at the same time, we cannot very confidently rule out the possibility of lymphoma as the patients have hepatomegaly, multiple enlarged lymph nodes, and night sweat, which actually favor the diagnosis of lymphoma. So after several rounds of discussion, we think there were only three options that we can try. The first one is to start the patient on empirical steroid to treat it as IgG4 disease, or either we obtain some more tissue through EUS or through lymph excisional biopsy. So eventually we involve some more specialists from our GI team and hematology, and the consensus is to repeat the lymph node biopsy. The reason behind is that they worry that starting empirical steroid, although it would treat the IgG4 disease, but sometimes it would also have some treatment effect on the lymphoma and mask the symptoms. For repeating EUS, FNB, the hematologist has some concern that they classically believe that lymph node can obtain more tissue for histological diagnosis and lymphoma typing. So at the end, we repeat the lymph node biopsy and show that there is a plasma cell-rich lymphadenopathy. And the pathologist is now able to commit that this is an IgG4 related disease. So our diagnosis was this is a multiple IgG4 related disease with pancreatitis as well. So the patient was given induction steroid therapy, and after several rounds, we can see that the very tight structure is starting to loosen up. So in summary, this is a case of IgG4 disease presented with jaundice and hepatosplenomegaly and lymphadenopathy. I think it will demonstrate that the EUS features sometimes can provide a lot of diagnostic value in this kind of arbitrary or difficult diagnostic cases. And often the time, multidisciplinary approach is very useful in these cases. So it's the end of my presentation, and I welcome a discussion and questions.
Okay, thank you. Thank you, Dr. Lo. Very interesting cases. The EUS features and the serological tests are compatible to the IgG4-related disease. But the clinical symptoms, for example, body weight loss, fever, but more likely to lymphoma. Interesting case. Okay. Vikram, do you have any comments?
Yes, a very nicely managed case. And although the EUS imaging of the bile duct, very nice case, Dr. Eugene. So you showed very nice images of now I can say with confidence typical bile duct involvement by autoimmune cholangiopathy and the autoimmune pancreatitis, MPD not dilated, tiny specks inside. The only catch now in retrospective is that the bile duct was obstructed without any lymph nodes compressing on it. So that was slightly against just a lymphoma. But yes, I totally agree that in practice, it can be very disturbing and very scary when the clinical pictures don't fit in. And you also told us very nicely that empirical steroids should not always be used because in many situations in lymphoma and even in some cases of pancreatic cancer, it can cause a partial therapeutic response and mask the symptoms. So very nice message. Thank you.
Okay. We also have several, no, not several, many lymphoma cases and diagnosed by ESFNA. At that time, we ordered we always order the flow cytometry. Flow cytometry is very useful. What's the hematologist's opinion? Your hematologist suspected lymphoma first or IgG4-related disease?
Actually, our hematologists cannot commit whether the patient has lymphoma because according to their opinion is that lymphoma would always require histological diagnosis. So we try to take as many FNB from the US as we can, but the findings is a bit equivocal. I think for the diagnosis of autoimmune pancreatitis, it's best to have histology showing IgG in the pancreas itself. So, in other words, the FNB here is not diagnostic, not of pancreatitis, not of lymphoma, and the hematologist is not comfortable to start the patient on any chemotherapy. So the advice is that we need some more tissue, and that's what happened. And indeed, our team and some of the other colleagues in hindsight wonder whether if we, take some FNB from liver or from or other parts of the pancreas, whether it would help. Because if IgG4 is a systemic disease, then wouldn't we are not sure. We're just thinking if the liver biopsy would also show features of IgG4 there, but we are not certain. It's just a discussion we had.
Okay. Luckily, this patient has also have the inguinal lymph node swelling. So you could get them much more sample from the lymph node.
Yes, the patient had very large lymph nodes. So as surgeons, we can take it out easily, and it's fortunate that the groin lymph node is usually very accessible. But if patients do not have this kind of lymph node, or the lymph node are inside the thorax or in the deep neck, then sometimes we do not have that luxury.
Okay. If they didn't have superficial lymph node swelling, what do you do?
I think I would have to repeat another EUS, maybe with a bigger needle, maybe talk more FNB from different sides. Yeah.
Yes, I agree. Okay.
We have two questions under the Q&A from Dr. Perry and Hara.
Okay, Kazuhara, did you perform same question. Did you perform flow cytometry? Because flow cytometry is very useful for diagnosis of lymphoma.
Oh, I think I'm not sure what the pathologist actually done for our lymph nodes. And I'm not sure if this the flow cytology is available in our lab or not.
Okay, another question is, in this case, FNB was made. Could Rose have been helpful to get the better tissue in first US?
Sorry,
okay. Could Rose rapid on-site evaluation, cytological evaluation was helpful to get
Rose.
better tissue? Rose.
In our center, our usual practice is to perform moles. I think Rose is, of course, very good. But I think the latest evidence suggests that if you use FNB needle with moles, it's basically, similar results to with Rose. But of course, in difficult diagnostic cases, it's often useful to have a pathology next to you, giving instant feedback. But again, as a setting in our public hospital, is very luxurious to have a pathology, be with you. Is often not that easy.
Okay, thank you. Okay, no more question from the audience. Okay, thank you, Dr.
Thank
Lo.
you.
Nice presentation. Thank you. Okay, let's move to the next case. Okay, next case will be presented by Dr. Shanshan Shen from Nanjing Drum Tower Hospital. Are you ready? Okay.
Yeah, I'm ready.
Okay, please.
Thank you, Professor Yasuda. It's my great honor to having me here to show my case because I still remember 10 years ago you came to our center and teach us doing the EOS. 10 years later, I have the opportunity to present my case. It is a very great pleasure. So I will. Can you?
Okay, we can.
Okay.
Thank you.
So okay, so the case I present today is early detected intraductal papillary neoplasm of the pancreas and the EUS and oral pancreatoscopy. Okay. So the patient is a female, 61 years old, and the chief complaint is recurrent abdominal distension and a little bit painful for over 4 months. And the enhanced CT of an entire abdomen show a slightly dilated pancreatic duct and mild dilation of the common bile duct and intra and extra hepatic bile ducts. And MRCP shows the similar result, just a slightly dilated of pancreatic duct. And he discharged from other hospital after symptomatic treatment provided relief. And he noticed she has a weight loss of 6 kilograms over the past years. And she came to our center at 2022, August 13. The past medical history and personal history is no significant finding. And from the laboratory tests, almost normal. And also the IgG4 is also normal. And we can see from the CT and MRCP almost normal, but just a little bit mild dilate of the pancreatic duct. Actually, in our outpatient department, we can see lots of patients like this, just a slightly dilate of the pancreatic duct. Maybe most of the time we will say, okay, maybe this is because of the old age or something, just a follow up, because all the laboratory tests is normal. But this patient come to me. I feel like she still need to do a EUS because MPD dilate more than 2.5 millimeter is an independent predictor of pancreatic cancer development. And also EUS is excellent methods to detecting the solid lesion instead of the MRI. So I did the EUS for the patient, maybe because the image is not very clear, because this EUS was not done in our hospital. Actually, it was done in other hospital, which is our partner hospital. They just start EUS, so I went to that hospital to help them. Even the EUS machine is good, but they don't have the high quality digital keyboard transformation. So after I see the US image in the computer, it looks a little bit not very clear, but during my scan, I still can see a very suspiciously hyperecho mass in the head of the pancreas, but the mass is not very deep, and also the lesion is so small, just 7 millimeter. So I'm not sure if this is a solid lesion or just a very early stone in the MPD, but I still feel like it is something. But if only EUS shows this, I don't think any surgeon will take the surgery because just that this small thing. So I suggest the patient do the ERCP and POP to our center. So I refer the patient and transmit the patient to my center. So we did the ERCP and do the POP. And from the POP, we can, I will show, from the POP, we can see the whole MPD is dilated, but just a slightly dilated, and we can see there is some problems here, and here the problem is from the POP looks like this, a very clear irregular lesion within in the head of the MPD, but the size is so small, just 6 millimeter in length, occupy 2/3 of the ducts, because in the POP, we can see the lesion so clearly. So at that time, we think even we don't get the biopsy very well, the surgeon will do the surgery after this. But still, we do the biopsy, and the biopsy showed this is a very high hyperdysplasia. So in this case, so from the biopsy pathologic, it shows extensive squamous metabolism of the mucus in the pancreatic duct tissue with high-grade dysplasia of squamous epithelium, which is very rare. It is not a regular PDAC, and also the immunohistochemistry shows the tumor cell express beta-catenin, and also the CK and P14 is very positive. So it is a high-grade squamous cell neoplasm in the pancreatic duct. And because of the finding from the ERCP with POP, and also the biopsy is very positive. So after the MDT discussion, the surgeon took the surgery, and finally the result is very good. And at that time, because we already did the biopsy previously, so finally finally the lesion is so tiny, just 3 millimeter here. And here we can see it is have a high grade intraepithelial neuroplasm, and also we can see the CK staining and the P40 is positive, and so this is a very rare, extremely rare pancreatic squamous neuroplasm. And we search the paper and see that there is only one case has been published before, but this case the lesion is very big, kind of big, and also it is not in the MPD, it is in the pancreas, and we can see from the CT scan. So do the surgery and kind of easy, but our case is just located in the MPD. It is very small, only located in the MPD. So the case summary: CT and RCP reveals only pancreatic MPD dilation, but EUS reveals a minor lesion with the pancreatic duct. Then the POP-guided biopsy performed and confirmed the diagnosis of a rare case. Because of the help of the EUS and POP, finally the surgical can be the decision can be done and do the treatment. So we report this case last year, and it already published in the endoscopy in last year. So take home message. So the importance of EUS in unexplained pancreatic duct dilation is very important in our center. If the patient has the MPD dilate, if the CT and MRCP can't tell the reason, usually we suggest the patient do a EUS. And also the EUS plus ERCP, the fusion technique, represents the future direction of the biliary pancreatic endoscopy. But we also should emphasize the importance of the MPD collaboration. Thank you for your attention.
Thank you for excellent cases. Congratulations on the publishment of this case. Thank you. Okay. We have 2 questions from the audience. Okay, first question is, Professor Donwanseo, should this patient be resected? How about following this patient periodically? Surgery can be delayed for several years. This patient has already operated?
Yes.
Yes. We
already did the operation.
Yeah. It's laparoscopic duodenal preserving pancreatic resection.
Yes.
And after that, after the surgery, do they follow up periodically this patient?
Follow the patient recovered very well and without any extra treatment, no chemotherapy.
Because this patient has a so-called carcinoma in situ, CIS.
Yeah, early stage. It's just similar to Panning 3, but it is not a Panning. It's a very rare tumor. Yeah.
Yes. Don't need periodical follow-up.
Okay, excuse me. I think the Donwanseo question means that if this patient have already a squamous cell carcinoma, is right, and then this is the minimal. I think it's maybe if we just follow this patient, how about that? Just to follow the main pancreatic duct dilatation, also EUS, and if this mass is enlarged at the time, we can consider the surgery.
Yeah, but we found it in a very early stage, and the patient can be a very because the don't need to do a very big surgery. It's just to do some local surgery.
Yeah,
okay.
This is a high grade dysplasia. Just
yes,
we can delay this.
Yes, this is a high grade dysplasia, not cancer. So,
Just now I didn't show the video, but if you would like me show the POP video, I also can show it if you want.
sorry?
We also have the POP video to see the whole MPD. If you want, I can show it, but yeah.
Yes, yes, we would like that. And what is the POP that you used, Dr. Shanshan?
Microtech,
Micro-
Chinese company.
Microtech.
It's
Very
very
nice.
clear. Yeah, yeah,
So
very
very
nice.
good. Can you show us the video?
Yeah, okay. I can show the. I can show it. Let me show.
What,
And
what's
your
the-
images were also very beautiful. They were good. The endosonographer picked up the very subtle thing. The US images were also nice.
Yeah, and this one. Can you see my?
Not yet.
Can you see my screen?
No.
Can you share the screen again?
No.
Share.
Okay.
Can you share?
Yeah.
Okay. Now.
Yeah.
Okay.
Yes.
So we did the POP and we check the whole MPD. We can say the lesion is so real, and we even don't until now we can't explain why the lesion is suddenly just located in the head of the pancreas. MPD and other MPD and is totally healthy, and besides this lesion, other pancreas is totally healthy. We can't see any lesion in other place, just here, very locally. Yeah, but the lesion is so clear, and even from the POP, it's very clearly, and we also can do the biopsy. So even if the biopsy did not diagnosis, but because of the visual diagnosis, the surgeon still can take the to do the surgery. Yeah, it's very clear.
Okay, another question.
Yeah.
Okay. Does the contrast enhanced US help in differential diagnosis for intraductal squamous neoplasm? Contrast enhanced US may be useful for diagnosis, but I don't think so.
But at that moment, I didn't thought it was a tumor. I feel like it's just a tiny stone. So just feel very weird, but I still think POP will help us a lot. And also it was not in my hospital, it's in other local hospital. They don't have the contrast option. So I didn't do it, but if in my hospital, we will do it for sure.
Contrast enhanced US is helpful for differentiate from mucus from tumors, but I don't think it's useful for differentiate squamous from adeno.
Yeah, and it is just a high-grade dysplasia. Haven't go to the tumor yet. Maybe the visual supply is also a little bit, yeah.
In practice, it is very small. I think even with contrast, you'll keep scratching your head. What was it? So
Yeah.
very small even for contrast. Maybe.
When we saw the video in the POP, I feel very excited because I found a smallest tumor, early tumor of the pancreas in the world.
Very exciting.
Yeah.
Oh, no. Okay. Other comments or questions from the audience? No? Okay, one more. I cannot. Vikram,
So
can you read this
So-
doctor's name?
Yeah, so Dr. Vishali wants to know how will the patient be managed, close follow-up or surgery. So I think the patient is already operated. So he operated. So
Okay.
from our side, he's cured.
Mm.
She's.
Okay. No more questions or comments.
Shall we move on?
Okay. Move on
Okay.
next case.
Okay. So it's my thank you, Dr. Shanshan. That was very nice. So it's my pleasure to invite the third case presenter today, and he's Dr. Weng-Fai Wong. He is the attending physician at the Department of Integrated Diagnostic and Therapeutics, National Taiwan University Hospital, Taipei, Taiwan. So Dr. Wang, welcome.
Hello.
Yes, please begin.
Good evening, everyone. I'm Dr. Weng-Fai Wong. Thank you for introduction. Can you see my slide?
Yes, we can see very well.
Okay. So it's very glad to be here to present a case in the first deep EOS education program. So this patient has repeat pancreatitis for months. He is a 52 years old man who had his first episode of acute pancreatitis in November 2024, which was managed in a local hospital. And this patient recovered well. However, 1 month later, the patient had a second episode of acute pancreatitis. Therefore, this time, he was transferred to our hospital to further management and to survey the etiology of repeat pancreatitis. For underlying disease, the patient has lung adenocarcinoma, which was reset 3 years ago and achieved complete remission. He also has gallstone disease, but he did not experience any complication of gallstone disease-related complication, so he did not receive cholecystectomy. When he arrived at our hospital, we performed a lab test for him, which showed an elevated amylase and lipase level. The liver function was normal. And we also checked the serum calcium level, and it was also normal. For the tumor marker, we checked CA and CA199. Both of them were within normal limit. We performed a CT scan for him, and we can see there are bilateral poor effusion, which may be related to acute pancreatitis. And the pancreas was quite swollen, and we can see a dilated pancreatic duct. And there was fast draining surrounding the pancreas, and there was a localized fluid collection near the pancreas. So after improvement of his pancreatitis, we arranged a US to survey the etiology of dilated pancreatic duct and repeat pancreatitis. Here is the US, and we can see the dilated pancreatic duct. And near the pancreatic body, the pancreatic duct was disrupted. And we inject contrast to see if there is any tumor. But for this part, it showed ISO enhancement. No tumor was found. However, we still suspect that there is a space-occupying lesion because the pancreatic duct was obstructed. So we perform SMB to take sample from this part. The pathology showing that it was a chronic pancreatitis with focal-rich eosinophil infiltrate. And the IgG4 count was low, so as the ratio between IgG4 and IgG, so type 1 autoimmune pancreatitis was less likely. And in order to further exclude the possibility of pancreatic cancer and type 1 AIP, we also perform a PET scan. It showed inflammatory change of the pancreatic body to tail, which was compatible to acute pancreatitis. So there is no pancreatic cancer and no autoimmune pancreatitis. So we gave the patient a conservative treatment and he recovered well and we discharged him home. However, about 2 months later, the patient has persistent fever and abdominal pain, so he visits our hospital again. We repeat a CT scan for him, and this time we can see that there was a pseudocyst near the pancreas, probably due to the complication of the previous episode of acute pancreatitis. And we considered the pseudocyst was infected. So after discussion with the patient, we decided to drain the pseudocyst with EUS. So under EUS guidance, we can see the pseudocyst very clearly. And we use a lumen opposing metal stent to drain the pseudocyst. And after stent deployment, there are some turbid fluid came out from the stent. And after this procedure, the fever subside, so as the abdominal pain. About 1 month later, after LAMP deployment, we repeat a CT scan for this patient. We can see that the cystic lesion was collapsed totally, and the location of the stent is very good. So we arrange a gastroscope to remove the stent, and we can see there are some granulation tissue within the cystic lesion, and there was no necrotic substance. And we capture the stent with a snell and remove this stent. After stent removal, the cystic lesion collapsed totally. So there was no space to deploy a plastic stent to maintain the thread. So in order to prevent pseudocyst recurrence in DPDS, we deploy a plastic stent into the pancreatic duct to cover the damaged part of the pancreatic duct. Here is the final location of the pancreatic duct. And after the procedure, the patient was fine, so he was discharged. But again, about 3 to 4 months later, the patient has progressive abdominal pain again, and he visits to our emergency department. So we repeat a CT scan for him. And this time, we can see multiple hypodense lesions in the liver. And there is a hypodense tumor at the pancreatic body, which was located at the previous cystic lesion. And here is the pancreatic stent. So we arrange EUS to take biopsy as soon as possible. Here is the tumor. It reveals bullish pattern under elastography. And we also inject contrast to prove it is a viable tumor. And there is some necrotic area within the central part of the tumor. And we use a FMB needle to take sample from the pancreatic tumor. Then we chose a hepatic tumor, and again we use a FMB needle to take sample from this hepatic tumor. And here is the result. The pathology revealed that for the pancreatic tumor, it was a poorly differentiated carcinoma. And for the hepatic tumor, it was a metastatic carcinoma. And we also checked the tumor marker again. You can see that for CA, it was below the upper normal limit all the time. And for CA1RI, despite there is a rapid elevation in July 2025, it also below the upper normal limit. So I think the patient maybe has a cystic ductal adenocarcinoma, or the other explanation of this case is that maybe the tumor obstruct the pancreatic duct initially and causing repeat pancreatitis and pseudocyst formation. And if we look into the literature, we can see there are so many case reports showing that pseudocyst may mimic or coexist with acute with pancreatic cancer. So we need to keep in mind with this differential diagnosis. So here is my presentation. Thank you.
Thank you, Dr. Wong. Very educational case, lot to learn for all of us, that in a elderly person, or at least those above 50 who develop pancreatitis without any obvious reason, we have to remain alert for a long period of time. What do you think? So don't you think that within 4 or 5 months the tumor increased a bit too rapidly in size? You couldn't see anything before, and in 4 months it was such a big tumor. So and also through metastasis. So was this slightly unusual to you?
Sorry, can you repeat your question?
Yes, so I congratulated you on the nice case, and lot for all of us to learn from this case, that in a older person we have to be very alert for carcinoma, cancer causing pancreatitis, because of early ductal obstruction can be the first manifestation. My question to you is that the tumor seems to increase very rapidly in size. You hardly saw anything. And then in the last FNB, the tumor was very big. So
Yes.
do you think that when you placed lamps, maybe the tumor was already present downstream of the pseudocyst? Could you have missed the tumor at that session? What do you think?
Actually, we have performed a CT scan before LAMS removal, and there is no pancreatic tumor or no hepatic tumor. So usually in our clinical practice, after stent removal, we will follow an abdominal ultrasound to see if there is any complication. And for the abdominal ultrasound, no pancreatic tumor was detected. So I think it is the tumor progressed quite rapidly. So even though we perform 3 CT scans in 6 months, we cannot detect this tumor earlier. So I think it's a quite challenging case for us.
Yes, that's a everyday problem for many of us. There is a question from the audience that could the pseudocyst be secondary to the FNA puncture? So the pseudocyst which happened, could it be a ductal leak because of the FNA?
Because the patient had a second episode of acute pancreatitis, and after resolvement of this pancreatitis, we performed the first FNB, and after the first FNB, the patient did not have clinical presentation of acute pancreatitis. So I do not consider the pseudocyst is related to FNB. Yes.
My other panelist, co-panelist, Dr. Yasuda and Dr. Kim, any comments?
Okay. I have a question. I think it's a very educational cases for detecting the early pancreatic ductal adenocarcinoma. Can you show us the video clips for initial US FNB?
Okay.
Okay. You drew the small mass lesion, just suspected, right? And then
Yes.
and then needle pass a little bit. I think maybe. I think it's, your needle pass is a little bit light side, light area. However, mass lesion is a little bit center. What do you think about that?
Sorry, Professor Kim. Can
Yes.
you repeat your question?
Okay, I think it's a needle target.
Oh,
Needle target is just the right side on
oh,
your video. Just I think maybe this small lesion is located in the middle side, middle area. Maybe just.
I'm not sure. Maybe we can puncture this way.
Yeah.
I think.
The low equi area, maybe this needle can make the low equi area. Okay, I think. Just
Thank you for your opinion.
I also think this lesion might be PDAC, pancreatic cancer. And after the puncture, tumor seeding with pancreatic leakage and cause pseudocyst, might be.
Okay, you mean maybe damage the pancreatic duct? Okay.
Any other question from the audience? Any comments? So there is a similar,
another question from the audience.
Yes, that's the similar question, whether the pseudocyst was a complication of the FNA, FNB.
Yes. Okay,
I think,
same questions. Okay. Yeah.
Basically, I think the same. Yes. Yes. Any other question from the audience? Okay, so I hand over the screen to Dr. Kim.
Yeah. Okay. No.
Thank you, Dr. Wong. Thank you for the nice words. Thank you.
Now we'll finish this first deep time, and then I think it's a wonderful time. I think, and then thank you to all speakers, moderators, and all participants for these great sessions. Today's discussion showed how US help us to see what other tests may be missed and help us make a better decision. Case presenter Dr. Lo, Dr. Shen, Dr. Wang thank you so much. We truly appreciate and then valuable comment from our expert faculty and Dr. Vikram, Dr. Yasuda. On behalf of Age Education Summit Committee, thank you for your support and participation. And we look forward to seeing you at next deep session. Maybe we'll prepare the interventional US. Next program, and then we will discuss prepared next deep program. Have a nice evening. Thank you so much, everybody. Goodbye.